My patient is a 13-year-old girl, resident of Pune, YouTuber, left-handed, studying in 9th standard, informant mother, reliability fair, presented with complaints of abnormal behavior since first week of July 2024 and recurrent abnormal jerky movements of the right upper and the lower limb since second week of July. In the first week of July, her mother noticed change in her behavior in the form of she frequently broke into tears, she was anxious, and she could not concentrate on her studies at school. She became stubborn and aggressive, hitting everyone at home while simultaneously apologizing for the same. She perceived as someone standing behind her, continuously speaking to her. She often felt sad, irritable, and fatigued. Her conversations were frequently irrelevant and illogical. On 7th of July at 14:30 hours, while coming back from school, she felt numbness in her right upper and the lower limb, which disappeared by the time she reached home. At the same evening, while lying down, she suddenly started shouting and tightly gripped her mother's hand with her right hand. Following this, she experienced an abnormal tightening of her right upper and the lower limbs for 3 to 4 seconds while her awareness remained intact. She appeared frightened, agitated, and shouting. She continued to have such multiple intermittent episodes over the next 2 to 3 days. However, in one of the episodes, she had tightening of both upper and the lower limbs with jaw clenching, and it lasted for 5 minutes. She regained consciousness after 7 to 8 minutes and was confused for 5 to 7 minutes.
Mr. Sudhindra, what do you think these episodes are?
That must be caused by any seizures, sir. Like with abnormal movements are there and postictal confusion was there.
Okay.
And before that there was an aura, sir. So it must be seizures.
Lalit, so how do you define seizures?
So seizure is abnormal, irregular synchronous activity.
Be a bit loud.
Seizure can be defined as abnormal, irregular synchronous activity of the brain.
Okay. Next, how do you define epilepsy?
Epilepsy is a disorder, sir, characterized by abnormal jerky movements of limbs.
No. I am asking you definition of, you are telling me the definition of seizures. Tell me the definition of, how will you define epilepsy? Next.
Seizures, epilepsy is defined as recurrent episodes of seizures occurring over the period of 24 days to hours to 1 week.
Galagod, can you define the definition? Please use the mic.
Sir, epilepsy is defined as a condition in which the patient has risk for recurrent seizures, sir. And in numerical terms, sir, 2 to 3 episodes of seizure is considered as epilepsy.
So seizures are transient events. They are symptoms or signs due to abnormal, excessive, synchronous neuronal activity in the brain. And how do you define epilepsy? That is at least 2 unprovoked seizures occurring more than 24 hours apart. Or if there is one unprovoked seizure, and the probability that over the next 10 years, the patient is likely to have one more seizure. So it could be due to an abnormal EEG, or it could be due to a remote structural lesions or a remote infection, or even with one episode of seizure, the patient, you can define the patient into a definitive epileptic syndrome. Carry on. So how do you classify seizures? The classification is here, so that it can be classified into focal onset, generalized onset, and unknown onset. So Abhishek, where will you place this patient?
So this patient has focal seizure with intact awareness. However, on this later episodes, the patient probably had focal seizure with bilateralization, since she had generalized bilateral movement of upper lower limbs as well as clenching of teeth.
So this is the latest classification of seizures, according to which we classify seizures into focal onset, generalized onset, and unknown onset. Now, the focal onset can be with intact awareness or with an impaired awareness, or it could be motor onset or non-motor onset. The term that we used to use previously of generalization or secondary generalization has been replaced with focal to bilateral tonic-clonic. Let's call it Robin. So why is this classification so important? Why do you need to classify seizures?
Sir, it is usually seen that, sir, focal onset seizures with intact awareness, they might have a correctable cause, sir. They usually do not progress to epilepsy, sir. Whereas focal onset seizure with impaired awareness, they can later become epilepsy, sir.
Dadagod, can you help him out?
So the management differs with focal onset and generalized onset seizures, sir, and it is also for the prognostication of the disease.
So the implication of this classification is that most of the times in focal seizures, you may find maybe an underlying interparenchymal pathology, or they might be more amenable to a surgical correction. Even if you are not able to find, even the management, the initial drug therapy that you are going to use differs in focal and generalized onset seizures.
She was taken to the private hospital where 8-hour video EEG was normal, her MRI brain was normal. Further, she was referred to a psychiatrist as a case of psychogenic non-epileptic seizure, and she was managed with tablet escitalopram, propranolol, and clonazepam. Her condition further deteriorated. She became more anxious and exhausted. She expressed a fear of death and cried continuously. Her life and surroundings were changed. She was no longer the same person. She was dropped out of the school and she struggled to perform her daily activities of living without her mother's help. She recognized everyone but showed sadness, aggression, and erratic behavior. She also had lost interest in making YouTube videos. She had slurring of speech with irrelevant conversations. And further, she stopped talking over the time. She also experienced twitching on her right side of face and abnormal movements of her right hand and lower limb. With this complaint, she presented to the Department of Psychiatry and of our hospital, and then was referred to neurology OPD to rule out any organic cause. The activity was not associated with any blurring of vision or dizziness. There was no history of palpitation, sweating, or abdominal pain. There was no history of bowel bladder incontinence. There was no history of sideways movements of the hand or the lower limbs. There was no history of fever, trauma, alternative medicines, or any history of headache or abnormal behavior during sleep. No history of night terrors, and no history of nocturnal enuresis. She consumed mixed diet. She had reduced appetite and sleep, and the bowel and the bladder habits were normal. She has a history of chickenpox in month of February, and she had missed her vaccination at the age of 9 and 18 months. She was a third order product of non-consanguineous marriage. She had she was full-term normal delivery and cried immediately after birth. She achieved developmental milestones as per the age. She attained menarche at January 24 with irregular cycles.
So these are the videos of Please go to the previous slide. Sunil, can you describe what is happening in the second video?
Sir, seems like Korea-like movements.
Okay. Next, Naveen.
So patient has the breathing movement of the hands, sir. So it can be brainstem like Korea
Okay.
and
Next.
belly motion be well.
Sir, it is a focal seizure, bilateral focal seizure without awareness.
Okay. So it is difficult to classify these movements. They are sometimes known as ictal rhythmic hand movements, or it could be just a presentation of a PNES. Okay, but given the history, it goes more in favor of a ictal rhythmic hand movement. Okay, next, who will summarize? Major Shrivaran, please summarize.
So we have a 13-year-old female with no prior comorbidities, with background history of having a chicken pox and not taken vaccination in the past. She presented with history of abnormal jerky movements, which was initially of a focal onset, then gradually developed into a focal to a generalized seizure.
So
With-
what do you think this patient is having? What are differential diagnosis at the end of history?
So this can be an infection, and considering her age, her early onset, and a female with a history of focal onset seizure, this can be an autoimmune encephalitis, and infection causes is also a possibility, sir, like meningitis and meningoencephalitis.
Meningitis would not cause this. Of course, meningoencephalitis, I believe. Next. What do you
And
think?
other metabolic derangements.
Okay. So, very good.
On general examination, she was averagely built with BMI of 18.7 kg per meter square. Her temperature is 98.6 with pulse 82 per minute, regular, normal volume and character, with BP of 100 by 68 mm of Hg, right arm supine, with respiratory rate 18 per minute and no pallid icterus, cyanosis, clubbing or lymphadenopathy. Her systemic examination, the CNS examination, the mini mental state examination score was 18 by 30.
Hello, good. Please go ahead. What is this chart known as? What is this scale, MMSE scale that she is using known as?
So this is MMSE Folstein.
Yes. So what are the fallacies of this?
Sir, in this one is it depends. It varies on the educational status of the patient.
That is
Sir.
not fallacy. Any second.
And it is
Major epsilon. Major Amanti.
Sir, the fallacy. So the fallacies of this is that the lobes are not equally distributed in this. For example, for parietal lobe, only the visuospatial constructional ability has been checked. So the parietal and the occipital lobes are underrepresented on this, sir. Like for parietal lobe, only the constructional ability has been shown in clarity here, like the agnosia, then the finger agnosia, the visual agnosia. These components, also stereognosis, has not been covered in this.
Or elaborated psychiatric neuropsychiatric assessment or lobar assessment. When we are talking about this tool, we are talking of as a screening.
Right.
So screening tool cannot be so detailed. If you find something wrong with screening, then we go ahead. So are there any other fallacies?
Sir,
suppose the person is got a very high index. So how is he going to bear on this screening tool?
So in that case, he would have a greater score, and we might miss out on the, like, even if the person has impending dementia, but they have a higher cognitive reserve, they might fare well on this score, which would be a false score, sir.
Yes. So this is known as screening index. So divisions of very high intellectual reserve, very high intellect baseline. So we may not pick up early signs of mental impairment in them. And secondly, cannot test abstract thinking and executive function.
Yes.
These are the cutoffs for Holstein MSc. So it is dependent on the education of the patient. So the for person who is educated only up to between less than 23 is considered as abnormal. High school less than 24 is considered as abnormal. And if the score is 17, it is considered as severe cognitive impairment. Score of 24 and above is considered to be normal. Next. So are you aware of any other cognitive assessments in this?
Sir, MOCA score can be done, sir. Then Addenbrooke's can be done, sir. Then in the bedside, immediately we can do clock drawing test also.
So anything for English speaking people?
Sir, all the tests have got their own Hindi versions also.
Anything else? Anything simpler than that?